Welcome to the deep dive. Today we're tackling a really foundational text in critical care, applied physiology and intensive care medicine. And look, if you're a medical student, a clinician, or maybe an educational content creator trying to get up to speed, this book is, well, it's essential. But let's be honest, it is also incredibly dense. So our mission today is to sort of cut through that complexity. We're going to give you a structured, scientifically rigorous summary of the most critical concepts, for clinical application. And we'll pull out those little gold nuggets that really turn knowledge into practice.
That's absolutely right. I mean, the whole point of this book really is that you can't succeed in critical care without bridging that gap between the basic science, the physics, the chemistry, and what you're seeing at the bedside. It's not just about managing machines. You have to understand these dynamic interactions between the heart, the lungs, the whole system.
Okay, so we've broken this down into 4 parts. First, we'll hit core respiratory physiology and gas exchange. Second, we'll get into advanced respiratory mechanics and how to prevent injury. Third, we switch gears completely to hemodynamics and the big paradigm shift in fluid management. And finally, we'll look at some specialized monitoring and critical syndromes. Okay, let's unpack this. So we have to start with the concept that I think trips everyone up. Dead space, or VED. Put simply, this is the part of the tidal volume that goes into the lung, but it just does zero work. No gas exchange.
Right. And physiologically, you've got 2 pieces to this puzzle. First is the anatomical dead space, VDAW. Think of it as the volume that's just stuck in the pipes. Your nose, your mouth, trachea, the big bronchi. Gas exchange just can't happen there.
And you can actually increase that VDAW just by adding equipment, right? The extra tubing?
Oh, absolutely. The connector on the endotracheal tube, the heat and moisture exchangers, the HMEs, all that adds up.
And this is maybe less intuitive, just by over-distending the lung, which stretches those airways out?
Exactly. Then you have the second component, which is often much more clinically important. That's alveolar dead space, or VDALV. This is volume in alveoli that get air, so they're ventilated, but they're not getting any blood flow. They're not perfused.
So the air gets there, but the blood doesn't. Pure wasted ventilation.
Pure wasted ventilation.
Yeah.
And the things that cause it are, the big red flags you see in the ICU.
Things like shock states, low cardiac output, pulmonary hypotension.
Right. Anything that kills the blood flow to parts of the lung.
Right.
Or, a massive PE, microthrombosis, anything that blocks the vessels themselves.
And this leads us right into hypoxemia. When your patient is not oxygenating well, the core problem is increased venous admixture. We quantify that as the shunt fraction, or QSQ.
And that admixture is made of 2 things. True shunt, where there's zero ventilation, think of a collapsed alveolus, and low VQ mismatch, where there's just not enough ventilation for the perfusion that's there.
And what's so fascinating is the limitation of that standard calculation. You get one number for the total problem, but it can't tell you if the problem is true shunt-like lungs full of fluid, or if it's just a lot of VQ mismatch.
Exactly, because the math has to make this big assumption that all the blood is either going through perfectly working lung units or through completely non-working ones. It tells you how big the problem is, but not, what kind of problem it is.
Which is why, for research at least, we have to talk about the multiple inert gas elimination technique, or MIG. It sounds incredibly complicated.
Yeah.
Why go to all the trouble with 6 different inert gases?
Because MIG is really the gold standard for mapping out the lung's function. It's powerful because it can actually distinguish between areas of low VJEQ, so mismatch, and areas that are completely unventilated, which is true shunt. And it does the same thing on the other end. It separates high VJEQ, wasted ventilation, from completely unperfused areas.
So it gives you a way to put a number on how messed up the lung is. That number being log SD for dispersion. A healthy person is around 0.4 to 0.66. But with severe ARDS, that number can just explode, right? Up to 1.5, even 2.5?
That jump just tells you how incredibly disorganized and damaged the gas exchange has become.
Now, you did mention it's a research tool. What are the limitations for, say, someone trying to teach this concept?
Well, the main thing to remember is that it's an approximation. You're trying to estimate the function of maybe 100,000 tiny gas exchange units with just 6 gases. So it's a fantastic tool, but it's not something you're doing at the bedside every day.
That unevenness in the lung, that heterogeneity, it leads us right into the problems caused by the ventilator itself, specifically intrinsic PEEP or auto-PEEP.
Right. This is PEEP that the patient generates internally because they just can't get all the air out in time.
High respiratory rate, short exhalation time.
Exactly. And the big clinical consequence, the one that's often missed, happens when the patient is trying to breathe on their own or with assistance. Suddenly, their work of breathing, their WOB, just goes through the roof.
Because they have to fight against that internal PEEP just to start a breath.
They have to overcome that PP plus whatever trigger you set on the machine. It's called an inspiratory threshold load. It's like trying to suck through a straw that's got a valve on the end that you have to pop open first.
That makes perfect sense. And speaking of WOB, to measure it properly, you need the Campbell diagram. For the learner, WOB is just the energy cost of breathing, right?
Basically, yeah. Mathematically, it's the area on a pressure volume diagram. And to get that pressure, we need to know the pressure inside the chest, the pleural pressure. So we use an esophageal pressure catheter as a stand-in for that. And the Campbell diagram just shows you how much effort the patient's muscles are making to overcome all the elastic and resistive forces.
Okay, let's connect that back to when things go wrong. When the patient and ventilator aren't in sync, you get these wasted or ineffective efforts. What's driving that?
Often, it's actually too much ventilator support. The machine is doing so much work that the patient's own respiratory drive gets suppressed. It's a neuromechanical inhibition.
So their own effort becomes too weak.
Exactly. It's not strong enough to overcome that PEEP plus the trigger pressure. So they try to take a breath, but the ventilator never sees it, a failed trigger.
This all leads us to maybe the most critical concept in modern ventilation, preventing ventilator-induced lung injury, or VILI. And that means we have to talk about the baby lung concept in ARDS.
This is such a massive shift in thinking. The ARDS lung isn't necessarily stiff in the way we used to think. It's fundamentally small.
Right.
The compliance we measure is actually really well correlated with the amount of normally aerated tissue, that small, healthy baby lung, and not the collapsed, consolidated parts.
So the big takeaway here is that protecting the lung isn't about setting a 6 milliliter per kilogram tidal volume based on the patient's ideal body weight. It's about making sure the stress and strain are okay for the healthy lung tissue that's left. The ratio of tidal volume to baby lung size is what really matters.
Absolutely. And protecting the lung that way often comes with a price, which is permissive hypercapnia. The PaTo2 goes up. But here's the really surprising part. The protective effects we see in ARDS models, they seem to be a function of the resulting acidosis, the hypercapnic acidosis, not the high CO2 level itself.
Wait, hold on. So you're saying it's the pH shift that's protective, not the gas?
Precisely. There are studies, for instance, in lung ischemia reperfusion models, where if you give the high CO2, but you buffer the pH back to normal,
You lose the protective effect.
you can completely abolish it. It's the chemistry, it's the cellular environment that matters, not just the gas concentration.
Here's where it gets really interesting. Let's move into hemodynamics, that heart-lung dance, and the total revolution in fluid management. We have to start with the old way. The limitations of static measures. For decades, we used right atrial pressure, RAP, and the pulmonary artery occlusion pressure, the wedge pressure. This book just confirms it. These static numbers have a terribly low predictive value for figuring out if a patient on a ventilator will respond to fluids.
And that failure is what drove this whole shift to dynamic markers.
Oh, yeah.
The classic example is pulse pressure variation, or PPV. The mechanism is really elegant. When the ventilator gives a positive pressure breath, it squeezes the vena cava, so venous return drops. That drop in RV filling then travels through the lungs, and a few seconds later, you see a drop in LV stroke volume. And that shows up as a variation in the pulse pressure on the arterial line.
So the patient's own circulation becomes a little laboratory for testing preload. But, and this is key for anyone learning this, PPV has huge caveats. You can only trust that number if the patient is in a regular sinus rhythm and is completely passive on the ventilator. No spontaneous breathing at all.
Right. If those conditions aren't met, if they're breathing a little on their own or they're in AFib, you have to use something else. And the best choice at the bedside is the passive leg raising maneuver, PLR.
Which is basically a self-volume challenge, isn't it? You're just moving about 300 milliliters of blood from the legs into the central circulation.
Exactly. And because you're not relying on the respiratory cycle, it doesn't matter if they have an arrhythmia or if they're triggering the ventilator, its predictive value is really high. If you see a PLR-induced jump in aortic blood flow of more than 10%, which you can measure non-invasively, that patient is very likely to be fluid responsive.
Okay, before we move on, 2 other circulatory points. First, pulmonary vascular resistance, PVR. The book warns against just calculating an isolated PVR number.
Yes, that single number can be so misleading, especially when cardiac output is changing. It's much, much better to interpret pulmonary hemodynamics on a pressure flow diagram. That gives you context. You see the whole picture, not just one snapshot.
And second, intra-abdominal pressure, IAP. So critical for spotting abdominal compartment syndrome. The source highlights that just feeling the belly or measuring the girth is highly inaccurate.
Sensitivity is something like 40%. It's terrible.
So you have to measure it.
The gold standard is still intravesical pressure, measuring it through the bladder catheter. But even that is easy to get wrong. Air bubbles, wrong transducer position. And the volume of saline you put in the bladder is critical. If you put in too much, say 300 milliliters, the pressure can shoot up to almost 24 millimilli VHG just from stretching the bladder. You have to keep that volume low. 50 to 100 milliliters ideal.
Okay, let's move into our final segment. Monitoring and some special topics. We've talked macro, now let's get down to microperfusion. Starting with the basics, pulse oximetry. It's great for spotting desaturation, but we have to remember its limits. A change in SpO2 doesn't always track with the PaO2 in critically ill patients, and, most importantly, it tells you nothing about ventilation.
To really assess tissue oxygenation, you need to look at venous oximetry, that's SVO2 from a PA catheter, or SCVO2 from a central line. These are so important because they reflect the balance between oxygen delivery and consumption. If those values are low, it means the body is extracting way too much oxygen. It's a major red flag for a mismatch.
And the clinical impact is huge. We know that SCVO2-directed early goal-directed therapy improves survival in septic shock.
It does. The main limitation to remember is that the central venous number, SCVO2, can sometimes be quite different from the true mixed venous, the SVO2.
And to get even closer to the tissues, non-invasively, there's sublingual capnometry. It measures the PCO2 in the tissue under the tongue.
Right. And the idea is that when perfusion to that tissue is bad, what we call a stagnation phenomenon, the CO2 just builds up locally.
So it's the gradient that matters, the difference between the tissue PCO2 and the arterial PCO2.
Exactly. A high CSLA-CO2 gradient, that reflects hypoperfusion. And the book makes a strong point. A gradient over 25 millimil of Hg is a really bad prognostic sign in unstable patients.
We also have to talk about lactate. Everyone sees a high lactate and immediately thinks tissue hypoxia, anaerobic metabolism.
And you must always exclude that first. But the book reminds us that lactate can rise for other reasons.
Such as?
Well, you can get aerobic lactate production, which is often tied to the massive inflammatory cascade in sepsis, or, and this is a big one, you can have decreased lactate clearance because the liver isn't working well or isn't getting enough perfusion.
So the number is a flag, but it doesn't always point to a lack of oxygen.
It's a warning sign that requires more investigation.
Okay, let's end with a really high-stakes syndrome. The effects of a subarachnoid hemorrhage, or SAH, on the heart and lungs.
This is all driven by a massive, uncontrolled catecholamine release from the brain after the bleed. A huge stress response.
And the consequences are just brutal. You see rhythm disturbances that can look just like a heart attack.
You get this reversible myocardial stunning, where the ventricle just stops pumping well and you get neurogenic pulmonary edema, or NPO.
And that NPO has a very specific two-stage process, doesn't it?
It does. It starts as hydrostatic edema. The capillary pressure shoots up past 40 millimeters of mercury, forcing low-protein fluid out. But then, very quickly, that pressure damages the capillary barrier, and it becomes a high-permeability, protein-rich edema.
So when we tie all this together, what's the big takeaway message?
I think the critical message is to avoid the trap of just trying to normalize isolated numbers. Don't think hyperventilation is always the answer for a brain injury, or that transfusing everyone to a high hemoglobin is always a good idea. You have to respect the complexity, the patient's individual context, and all these nuanced physiological mechanisms we've just talked about.
So what does this all mean? It means you have to understand that critical care is dynamic. And relying on static numbers or one-size-fits-all protocols without understanding the why behind them is, well, it's a recipe for error. You have to use these tools to inform your judgment, not to replace it. All right, let's finish with a quick review exercise for you, the learner, just to help cement these ideas. Imagine you have a patient with severe ARDS. They're on controlled mechanical ventilation, they've been stable, but now they've suddenly become hypotensive, and your first thought is, maybe they need a fluid challenge.
So here's the question. Given everything we've discussed about hemodynamic assessment, why would relying solely on the pulmonary artery occlusion pressure, or the pulse pressure variation, be potentially misleading in this specific patient? And what single alternative bedside maneuver would you perform to reliably confirm their preload status before giving any fluid?
Think about that dance between the heart and the lungs, the caveats for each measurement. It forces you to choose the most robust tool for the job. That wraps up our deep dive into applied physiology in the ICU. Go forth, be well informed, and remember that the baby lung is small, not stiff.